Namaste, Daruji. Namaskara. How are you, sir? You are muted. You are muted.
Bhaskar, I am also facing problem with my video.
Hello? Hello?
Yeah, Mahesh Moite here. I am also facing problem with the video. I'll change the laptop. There's problem with the Zoom on my this thing. So I'll change the laptop. I'll get joined from another
Okay,
source.
okay, okay, okay.
Mahesh Moite here. Namaste, Dr. Daruru sir.
Hmm.
कितना तो लैपटॉप डाला के तुझे तुला पीपीटी फॉरवर्ड कर के देखा तो उनका
Mahesh, I should make you host.
I don't know what is happening. हे पण केलं
You exit and then join.
I tried that yesterday. Yesterday also there was some problem. I in fact deleted that software and again reloaded it. The problem still continues. I'll check with that later. But
I'm
just
also
now,
not able to start my video somehow. I don't know.
yeah, there's some problem on my end. But I'll join from other source.
At airport, Nagpur airport. Bye.
Link का WhatsApp में मिल अभी पण फॉरवर्ड करतो याच्यात email च.
कुठला इकडचं वायफाय कुठलं
हा?
वायफाय कुठला इकडचं
अं,
Live streaming has started, sir, on YouTube now.
याच्यात hotspot केलं.
नाही हॉटस्पॉट एवढं काही
Hello, Manish. You have Iram's number?
Oh, mobile number I don't have.
Okay, she has not joined, no, yet?
Not yet.
Okay, I'll just call her and come back.
Yeah.
ಬರಲ್ಲ ಬರೋಬ್ರಲ್ಲಿ ಅಂತ ಹೇಳೋದು ಮಾತ್ರ ಬೆಳಿಗ್ಗೆ ಕೇಳಿದ್ರೆ ನಾವು ದೂರ ಇರೋದಂತ ಅದೇ ಪೇಷಂಟ್ ಹತ್ರ ಇರೋದು 5 ನಿಮಿಷದಲ್ಲಿ ಬರ್ತೀನಿ ಅವನಿಗೆ ಇದು ಮಾಡಕ್ ಒಂದೆರಡು ನಿಮಿಷ ಪೇಷಂಟ್ ಬಂದ ಇವತ್ತು ನೋಡ್ಬೇಕು ಬೇರೆ ಅಲ್ಲೊಂದು ಮೀಟಿಂಗ್ ಬೇರೆ ಇತ್ತು ಅವ್ರಿಗೆ ಆಕ್ಚುಲಿ 9 ಗಂಟೆ ಬರ್ತೀನಿ ಹೇಳಿದ್ದೆ ಬಟ್ ಬರಬೇಡ ಒಂದು ಕೊಟ್ಟು 9 ಗಂಟೆಗೆ ಬಟ್ ಅವ್ರಿಗೆ ಹೇಳಿದೆ 15 ನಿಮಿಷ ಇದು ಮುಗಿದು ಕೂಡಲೇ ಬರ್ತೇನೆ ಅದರಲ್ಲೇ ಯಾಕೆ ಹೇಳ್ಬೇಕು थांब 2 मिनिट चालू आहे फक्त. एकदा ते शेअर करून बघतो, एकदा सुरू झालं की बघतो.
Now you are visible, Mohite.
Yeah.
Nice to see you. Congratulations first.
Thank you very much. फुल स्क्रीन घे ना. हे इथे फुल स्क्रीन काय येते?
मनीष भी तुम्हारा फोन होता?
शेअर.
Yes, sir. बस just
Hello.
आना मत.
Abhay bhai.
Yes, how are you?
કેમ છે? મજા મે છે?
મજા મજા.
સારો છે?
સારા છે.
परफेक्ट.
दिसतंय का तुमचं? हे बंद करा बघा. तुम्हाला ते ऐकू येईल. हा तुम्हाला विंडो छोटा करू का? हा विंडो छोटा करू इकडे.
काय बरं?
हा अख्खा दिसायला पाहिजे.
हा सिंगल. ठीक आहे.
प्रेझेंटर मोड हा.
हा काय? हा हे माहिती आहे. तरी
इथे संपा.
हा तू थोडा वेळ थांब. मग तू मोबाईलवर जेवण होशील ना? टॉप शेअरिंग का होत नाहीये?
स्क्रीन शेअर झालेले ऑलरेडी.
सर आपका नेम भी चेंज कर दीजिएगा मोहिते सर.
अच्छा क्लिक करायला लागते का? अच्छा नॉट सिस्टम.
आणि हे ग्रीन कलर की मोठं.
स्टॉप शेअरिंग.
स्टॉप रे.
महेश का डॉटर इन लॉ का नेम ही है.
हो मला हे तुझं.
I'll change it.
Yeah, now I could do it, but I have joined from my daughter-in-law's laptop.
But your name is changed, Mahesh.
Yeah.
I just
She
changed
changed it now.
Now change.
Yeah, it's changed.
Chetan, can we go?
Yes, sir. I think Chetan bhai is traveling to Nagpur, so
Acha. Okay. Pulmo, respi,
Ped
something.
Pulmocon. Yeah, Ped Pulmocon.
Ped Pulmocon. All permutations.
I'm in a flight, so I might. Yeah.
Okay.
Manish is going to take care of everything.
No problem.
So, should we start, sir?
Madam
Yes.
आ गया ना? Ira
Madam
ma'am.
आ गई.
Madam has
Just
come.
check it
Madam
out.
has come. Madam has come.
Correct.
मैडम आपका वीडियो एक बार.
ಇಲ್ಲ. Good evening, Dr. Ira.
Good evening.
Welcome.
Good evening everybody. Good evening.
So, should we start, sir?
Yes.
Yeah. So, good evening, everyone.
1 minute. There is some.
Madam,
disturbance.
your second device
I
is
think
there.
Ira has joined from 2 devices.
Yeah.
Yeah, can you hear?
Yeah, मैम आपको second device log out करना पड़ेगा.
Second device.
आपका मोबाइल में या किसी में होगा चालू.
You want me to log out from the also?
इसमें सही है लैपटॉप में, पर कोई और भी डिवाइस आपका चालू है.
कोई डिस्टर्बेंस आ रहा है मेरे.
The echoing, it is echoing.
Yeah, some disturbance is there.
नमस्ते अभय भाई. Good evening.
नमस्ते महेश भाई.
नमस्ते Dr. Ira.
Good evening.
Good evening, Dr. Ira. Good evening.
everybody.
A lot of echo.
या मैंने मैडम को म्यूट किया तो आवाज बंद हो गई क्योंकि शायद वहीं से आ रही है.
Hello. Yeah.
चेतन भाई मजा में.
Dr. Ira has joined with three. She has joined with 3 devices.
Two are visible.
Maybe, madam, you have logged in twice.
Okay, I logged in twice. Yeah, okay.
Even one more still pending.
No, now I've closed everything except
No,
for
There
the
are 2. Still there are 2.
मैम
there are
आपका
two.
फोन बंद कर दीजिए, आपका लैपटॉप चालू है आई थिंक.
No.
I switched off the laptop.
Manish, can you just log her out? Can you
but
do that?
मैडम दूसरे
No,
में वीडियो ऑन
I'll
कर
switch off the laptop only.
No, but then laptop is required, ma'am.
हाँ, this is fine, ma'am. It's okay. This
This
is
is
fine.
Yeah,
fine.
now it's nice. Now you're on laptop.
Yeah.
Okay.
हाँ. So should we start, sir?
Yes.
Yeah. So good evening, everyone. Welcome to the fifth episode of Pediatric Clinical Case Series of ID series. As we have already done 4 episodes with Dr. Tanu Singhal ma'am, and our experts are Dr. Bala sir, Dr. Baldev Prajapati sir, Dr. Pramod Kulkarni sir, and Dr. Vijay Evle sir so far. This time we have a new presenter, Dr. Mahesh Mohite sir. First of all, we'd like to congratulate on behalf of PIDA for being elected as Joint Secretary Admin for the year 2026 and 27 for Central IB. Congratulations, sir.
Thank you. Thank you very much.
So before we start today's session, I request our chairman, Dr. Bhaskar Shinoy, sir, to say a few words.
Good evening, everyone. Welcome to the present episode of interesting case series. And as you know, we are just recovering from the NCPID now. We are in the post NCPID era. And today, you know that we have a galaxy of experts in the pediatric infectious disease. Dr. Mahesh Mohite will be presenting the case, and experts like Dr. Ira and Dr. Abhay are discussing the case. So it is going to be a very wonderful and interesting discussion today. Without wasting much time, I again thank you very much for joining the meeting today and your interest in taking it forward. Thank you so much.
Thank you very much, sir. So now, without wasting much time, we'll proceed with our session. So before we start our session, it's my duty to introduce our experts and presenter, though they don't need any introduction, all of them, 3 of them. But still, I would like to introduce them in short. Our presenter is Dr. Mahesh Mohite, sir. He is a pediatric and neonatal intensivist at Sai Children Hospital, Panvel, Mumbai, and Vijayawada. He was past president of IP Intensive Care Chapter 2022 and scientific convener of DIP. And he has done the Dr. PM Udani oration also. Welcome, sir. Dr. Ira Shah, madam. She is professor HOD of Pediatric Infectious Disease, Pediatric Gastroenterology and Hepatology, Vijayawada and Navroji Wadia Maternity Hospital. Madam is a nodal officer of Pediatric Drug Resistant Tuberculosis State and Center of Excellence and Pediatric HIV and ART Center. Welcome, ma'am.
Thank you. Good evening.
Yeah, good evening. Dr. Abhay Shah, sir, if I introduce him, our session will be too short. I'll introduce him in just important highlights. Sir is a member of ACVIP 2020-21 and 2018-19. He was EB member of CIP 12-15 and 2018 and member of ID working group of IPA 24-25. He has various publication and book chapters of more than 100 under his name, and he is the resource person of contributor for many more than almost 30 IIP modules. Welcome, sir.
Thank you.
Now I request Dr. Mahesh Mohite sir to start with the session.
Let's start sharing my presentation. Can you see my slides?
Yeah.
Can you
Yes, sir.
hear me?
Yes, sir.
Yes, we can hear you.
Yes. So first of all, thank you very much for giving us this opportunity on behalf of all 3 of us. I'm sure I attended all previous sessions. I think I missed only one. And I've seen the quality, the level at which it is being conducted all throughout so far. What I did this time is I haven't taken any complicated cases, but I have taken some complicated decisions here. And at the end of the session, perhaps I don't know where we take all of us, but I'll try and take you to some kind of a conclusion, some kind of challenges to the defined protocols, and let's go with the things first. So here is a case. 1 minute, huh? 1 minute. Yeah. So here is a 7-month-old female child, girl child. She was born of a first of non-consanguineous marriage, brought with fever for 7 days, high grade up to 102, irritable in last 2 to 3 days, no history of coryza, cough, no history of loose motions, no rashes, no red lips, no red tongue, nothing otherwise. Birth history,
Normal vaginal delivery, nothing significant, 2.5 kg birth weight. Immunization complete till date. Developmentally, she's appropriate for age. The treatment history, of course, she has taken treatment outside in the last 1 week. She has received a course of antibiotic, amoxiclav so far. The fever persisted in spite of that, so she is brought to us. On examination, she is 7.6 kg. At birth, she was 2.5, and she is 7 months now. Irritable, but not sick looking child. The vitals are stable. There is no rash, no lymph nodes, no organomegaly. So at this point, I want to ask both my experts, how will you go about 7 days without focus? Nothing really helping you. One course of antibiotic already given. So any of you can take Dr. Abhay Bhai, followed
Yeah.
by
Okay, go. Please go to the first slide.
first slide. Okay.
Yeah. So here we have got a immunocompetent child who has been immunized as per the age, and there is a short duration of fever, and there is no focus. So, Mahesh bhai, in the history, is there some outbreak is going on or that I want to know, number one. But looking at the fever, which is 102, which is probably not responding to our antipyretic, and the child is irritable, and I presume that child is not well during the interfebrile period. And if it is so, probably the bacterial infection would come into mind. I would think of the condition like, of course, I will do a general examination, systemic examination. We'll look at the enterofontanel. We'll look at the enterofontanel. We'll look at the hepatosplenomegaly, lymphadenopathy. Of course, there is no rash, nothing is there. But I will also look at the throat examination. And after doing everything, I find that if everything is normal, I think it's a fever without focus. Child is reasonably or moderately sick, may not be that serious. And that the things come in, it can be some acute otitis media. It can be some complicated UTI. It can be a partial septic meningitis because the child has been exposed to an antibiotic. And of course, there are no other features, but irritability and fever. I think some vasculitis or Kawasaki will come to mind. So the 3 or 4 are the usual diagnosis in absence of the epidemiological clue. If some epidemic clue is there, probably I may consider some dengue fever, some malaria or the scrub typhus. But otherwise, these 4 or 5 things comes to my mind.
Yeah. So presently we are not running with any of those malaria. We don't hardly see any
Yeah,
malaria outlet,
yeah.
honestly. Dengue, occasional patient, yes, but not again very common. And no other findings, no ear tenderness, throat is normal, pharynx is normal, no lymph nodes, as I said. Dr. Ira, madam, you want to add something to that? What Dr. Abhay Bhai said?
Yes, I think Dr. Abhay has actually given it very nicely. So the first thing when you think of in a child who comes as an infant and fever without a focus is obviously a UTI that you would think of first. And otitis media, even if they don't have any, they keep on picking the ear. So one history that we have to ask the parents is, does he keep on picking up the ear? If that is there, then you think of otitis media. What about the anterior fontanelle? Was it level? Normal anterior fontanelle.
Yes.
So again, that is not fitting into. The other history that I would like to know is, what is the feeding? Has the child started weaning?
She started on complementary feed at age of 5 months. She is still having breastfeeding and reasonably adequate feeding plus additional complementary feeding.
So that is another history that you would like to ask, is whether they have started feeding. Are they giving water to the child? Because usually you would not expect enteric at this age, but if there is an unhealthy weaning aspect that has taken place, then you will also keep that in mind.
So let me add, she's from she's a daughter of a class 1 officer of Maharashtra state, coming from Mantralaya. So let's
Okay,
on
so
how
then
the
we don't
pressures
expect
increase.
enteric fever.
Yeah, so
But we
reasonably
would
well
also,
qualified people.
yeah, we would also like to know history of travel.
In fact, they were to travel to their native, but a child fell sick, so they could not.
Okay.
And
Okay,
then
so there's no history of travel.
No.
Yeah, so I think you would first keep in mind is probably UTI, and then whatever is the seasonal fever at that moment in time, you will keep that in mind.
Perfect. I think let's move ahead because there is nothing more to discuss in this at this point of time. So provisional diagnosis at this fever without focus. As up to date gives the last edition gave very common reason for that. Many times is pneumonia, UTI, Kawasaki is in fact on very high on the card. But just now we don't have any clue. So on admission, we sent her investigation that included a blood culture, urine routine culture. Urine already was done, and I'll tell you the report which she came with. CBC, CRP, and system functions as a kind of a basic protocol since she was more than 7 days fever. Fever pattern. So we didn't start anything immediately. We thought we'll just document the fever pattern for next 24 hours. And these were the investigations we got at our end. So she got admitted on 16th and 17th. We had this investigation in hand. 2 days prior, they had done all these other investigations. You can see counts are on the neutrophilic side. Hemoglobin is low, she's anemic. And CRP was borderline. Now it's increased to 42. ESR is 85. Procal is normal. Blood culture already they had done on day 5, which is sterile. Infective workup, dengue they did, malaria they did negative, OTPT is normal. Urine was showing 15 to 20 per cells. And by the time they reached us, urine showed Klebsiella pneumoniae, more than 10 raised to 5 colony count, sensitive to meropenem. But USG was done, which was NAD, was normal. Now, with this, what's your take next?
So here, definitely the child has some anemia, which may be nutritional, maybe because of some chronic illness which is going on in the body, number one. Number two, the counts are very high. Of course, there is no polymorphic lymphoma because the second week probably there will be polylymphoma, some change. There is, I see some early thrombocytosis as well. Blood culture is sterile and the urine has a pus cell. Now, this pus cell can be a sterile pyuria, but here the 10 raised to 5 cyclic colony count Klebsiella is there. But I wonder in this 7-month-old child, the E. coli should be a combination. Why the Klebsiella is there? That is number one. But again, in 10 to 12% Klebsiella can be there. So here it can be a urosepsis or the UTI, or it can be a Kawasaki disease presenting with a sterile pyuria. Of course, the Klebsiella is there, but how the urine was collected, what is the method, all these things I will go, and will definitely go for the nitrite and this LDI, this leukocyte esterase. If the nitrite is positive, I think they are more specific compared to this. Though culture is positive present, but I think this also we have considered that. So these two things are in my mind.
Perfect, perfect. You made one comment, anemia, whether it is chronic fever, just for my knowledge. What do you mean by chronic? I mean, which is that chronic? How long it will work? Not in this case. Not in this case.
Yeah.
But in general, you said anemia caused by chronic, then how chronic? How long? What duration?
No. If the fever may not be chronic, but the illness may be a chronic, maybe more than 1 month or 2 months, where the child is not gaining weight, some appetite is down, sometimes some systemic disease is going on, something like that.
Here it is only 7 days.
Yeah.
And I'll tell you the hematocrit, his indices were more of a microstatic hypochromic suggestive of a nutritional anemia. And there was no significant organomegaly as well. So very likely nutritional anemia. Shall we move further?
Yeah, I think you can.
So fever recorded in 24 hours, she had 3 spikes of 102 at this point of time. So Dr. Ira, what do you do now?
I think you would have to start an antibiotic based on your DST pattern of the urine culture.
So we started meropenem for her because that was showing sensitive and rest was resistant. And she had 7 days fever without focus with a urine 15 to 20 per cells and culture grown positive. We started meropenem. USG KUB was normal. Fever, in spite of that, continued after 3 days. Now what do you do?
Okay, so I think if you have started meropenem, what dose did you start?
We started with 40 mkdo stat first dose and 20 mkdo 8 hourly.
And what was the way that you were giving? Were you giving it as an infusion over 1 hour, or what was the way
that's our protocol in my hospital. We give it over 1 hour infusions. Meropenem
so
we give over 1 hour. Yeah.
And what was the MIC of meropenem that you had on the culture?
It was showing sensitive. I didn't check it, but it was clearly showing sensitive. I suppose it's definitely in my lab when I get less than 4. So usually that's what they label it as sensitive.
Because meropenem is a beta-lactam, it works at the cell wall. What you need to do is sometimes when you don't see a response with meropenem, you need to increase the infusion so that you can maintain the drug level above the MIC for a period of longer time. So sometimes 1 hour infusion don't work. In that case, you may give 3 hours infusion and see the response. But usually you would get a response in 48 hours. If you're not getting a response in 48 hours, you would repeat the labs again. You would do a CBC, a CRP, and ESR again. You would do a urine routine, urine culture again. That's what I would do.
Yeah, Dr. Abhay Bhai, you want to say
Yes,
something?
I agree with what Dr. Irasa said that we will go for the serial CBC CRP count because your procal is only 0.4. It is not strongly positive. So though the leukocytosis is there, anemia is there, I think I have a doubt whether it's a Klebsiella the true infection or not, something like that. Because if it's a Klebsiella sensitive meropenem, I think within 48 hours, I think the child should respond. That is what my clinical.
Absolutely.
That is why my clinical experience there. So I think we have to take this culture positive with a pinch of salt, and we'll go ahead with some other parallel thing which is going on in the body. Maybe some Kawasaki like maybe happening in that.
Okay. So I noticed that. So you wanted to have further more CBCs. So we said, and you already mentioned, yes,
Yeah.
it can be Kawasaki, right?
Yeah.
So we did echo.
Yeah.
Considering that, so
Mm.
echo was normal.
Yeah.
Pro BNP was normal.
Mm.
And this was a protocol given in circulation. This is one guidelines given in circulation that is in recent one, and which clearly states this kind of I would say guideline that 1 minute, let me put it on one side. This one. Yeah. So children with fever for more than 5 days, more than equal to 5 days, and two compatible clinical criteria, or infants with fever more than 7 days without any explanation. If that is so, like our case, more than 7 days without explanation, assess laboratory test. If CRP is less than 30 and ESR less than 40, then serial clinical and laboratory evaluation if fever persists, echocardiogram if typical desquamation develops. If CRP is more than 30, ESR more than 40, then 3 or more lab findings, which is anemia, platelet high, albumin low, raised ALT, WBC more than 10,000, urine more than 10. So our child satisfies 4 criteria of this, or abnormal echocardiogram. If that is so, then treat it like Kawasaki. This is what is recommended by circulation, and this is what we followed. Yes, Dr. Abhay, you wanted to say something?
Yeah. So these are latest guideline, I think, from Royal College of Medicine in Australia.
Yeah.
And they here probably I would, rather than going for pro BNP, I would also test for the statewide echocardiogram.
We
And
did.
maybe a follow, no, not maybe a follow-up echocardiogram may be required for next week.
That will be after 2 weeks and 6 weeks. So we did this on day 7. That will be after 2 weeks and 6 weeks.
Yeah.
Right. And you may be following it up with these parameters again, but
Yeah.
echo will be after 2 weeks another. So we gave, we were based on these guidelines, we gave IVIG to this child.
And how was the protein and sodium in this case?
Protein and sodium, there was no significant albumin drop, and sodium was normal. I didn't put it for the sake of presentation part, but otherwise there was no change in that.
Because hypoalbuminemia is very common with Kawasaki.
Sorry?
Hypoalbuminemia is quite common with Kawasaki.
Yeah, absolutely. So provisional diagnosis was KD, incomplete KD we label it as. Points in favor, fever, elevated inflammatory parameters, neutrophilic leukocytosis, thrombocytosis. No other infectious focus which we documented in this child. So we give IVIG with aspirin small dose. Now, infantile KD, the
Dr.
guideline today.
Mohite, on
Yes.
this child, over a period of time, did the child develop a strawberry tongue, cervical lymph nodes,
No.
activation of BCG?
BCG scar.
No,
How was the
we
BCG?
were looking for it because we were looking this diagnosis. We didn't get, but that's a guideline which is given infantile KD suspect, the one which I told you. And that's why, since we didn't have any documented focus, we gave it. Actually, the
Did you
treatment
repeat a
part,
urine routine, urine culture?
we did. And that was Klebsiella, I told you.
Yeah, but after that, again, after the meropenem
After
non-response?
immediately, no. No, we didn't repeat again.
Okay.
Yeah. One fallacy, I agree, it was collected outside, but once you receive meropenem for 3 days, it's going to be further more fallacious. It's unlikely that something will be left behind after that, so we didn't do it again. Right. So now, actually, the guidelines for KD today in an infantile age group is IVIG and steroid both. But here, since we didn't have a definitive diagnosis, we didn't give steroid. We gave IVIG alone, and we give aspirin to this child. Now, this is what following. So 17th I gave you, this is 20th and 23rd. Not much of a significant difference. Hemoglobin is still low, platelets are slightly rising, counts are okay, CRPS are SGOTPT, and now you see albumin is 4.3, Dr. Abhay Bhai. So was quite all right.
Yeah.
Okay. So this is where we were. So here we are, fever for 15 days, aspirin IVG received, fever decreased for next 24 hours a bit. So up to 24 hours after IVIG, child remained afebrile. Fever recurred after 24 hours, again still 100.5 and at times again climbing to 102.
So,
Repeat echo we did at this point of time because that's our protocol in Kawasaki. After 48 hours, we do look for it, but generally recommended is 2 weeks and 6 weeks. So we did that and it is still normal. Nothing in that. Now what do I do?
so I think now the case is quite open. Number one, that probably the IVIG might have prevented the development of aneurysm. Number one, that we can say. And second thing, sometimes it may not be a vascular, but sometimes something like sogia, the anemia, the thrombocytosis, the leukocytosis with polyturbinance, cultures are going to be negative. I think, and no response or partial response to IVIG. I think we may think other than KD something else.
Dr. Ira, you want to say something?
Yeah, so at this moment in time, I would repeat the cultures. I would do a urine culture, I would do a blood culture, and also send the autoimmune markers. So you may do an ANA and take an autoimmune call here.
Okay, so we are moving on the autoimmune direction.
Yeah.
Let's see what we did after that. So infantile KD treatment recommendation is IVIG plus steroid. We were not sure whether we should give it steroid. Will you give steroid if you suspect strongly in this child?
No, you will have to rule out infections first
Yeah,
before
I
you
would
use
first.
steroids.
So
I
what
would
do you want
first-
to do for that? More than you said cultures, but as I said, we already given meropenem 3 days. It will have its own limitations. I mean, which of those organisms we gram positive we don't suspect in this child, gram negative most of them will be responding to meropenem.
So, doctor, there are number of other mechanisms for the meropenem resistance as well. So I think probably we can take the help of this molecular test also, whether it's a real UTI or not, it's meropenem.
So what test you want to do?
Maybe some karma or something like that.
But it is not meropenem resistant. It is
Yeah,
shown sensitive. It was shown sensitive.
No,
The
but it is
sensitivity
not working in vivo. That's what I'm telling.
Yeah, but generally Carba expert, once you give culture, if
Yeah.
you see resistant, then you will
Yeah.
go for Carba expert. Here it is
Exactly.
showing sensitive.
Yeah.
Here it is showing sensitive. So why
Yeah.
do I do it?
Yeah. Okay.
Yeah.
Now there is no clinical response. That's why I'm telling you.
I understand, but at this
Okay.
point of time,
Okay.
I agree with you that routine and culture can be repeated,
Hmm.
but we didn't follow that track. We thought
Okay.
let's rule out any hidden infection because sometimes
Yeah.
in the thorax and the deep abdomen you may be missing something. So we did USG which was negative.
Yeah.
So we
So
thought we should do before giving steroid, since we are strongly suspecting KD, before giving steroid, we'll do a CT thorax
CT,
abdomen.
yeah.
Because you are
Right.
already in the second week,
Yeah.
almost completing 2 weeks.
Yeah.
So we did the ideal protocol before empirical steroid. Whenever we give, there are few conditions where we at times are forced to give it. But before that, we do CT thorax abdomen. We have to do bone marrow definitely, because we have seen the normal counts and abnormal bone marrow. Maybe at times malignancy has been picked up, and 2D echo. So 2D echo we had done twice. Bone marrow we are holding on. We thought we counseled the parents to do this, and we said we'll do CT thorax. If that is coming normal, then we'll have to go for bone marrow, and they're willing for it. So now we did a CT thorax. And this is a CT thorax, which showed few enlarged lymph nodes noted in paratracheal and subcarinal location, largest being 10 by 10 centimeters, few with central necrosis. Right?
Yeah.
Now what's your take?
So very unusual. With central necrosis, you would actually think of TB, but with TB, you would not expect counts of 30,000. So is there any TB contact?
Nothing that we could evaluate, but child is 7-8 months. There is some house aid available. He's a class 1 officer. Many people is travels here and there. So we don't know.
We can hit the node with a tissue biopsy, number one, and we can rule out whether it's a Chiari granuloma or the non-Chiari granuloma. If it's a non-Chiari granuloma, I think the difference will be going to be different side, maybe some other causes, not TB, maybe there. But sometimes it maybe sarcoid can also present, like, so I would go for the calcium, ACE, something like
But there is a necrosis above by. So sarcoid is again a non-caseating.
non-caseating. That's why I say I will look at the
necrosis and caseation is TB unless proved otherwise for
but that is there are imaging. I would look at the histopathology and then confirm.
How do you get that? It's in the deep thorax. How do you get that
1
7
centimeter
Yes.
node, it's difficult to do a
Yeah,
biopsy.
it's a
So, and there are no lung parenchymal lesions that you can do, do a GL or something.
mm,
The best option here would be to look for indirect evidence is do an interferon gamma release assay, see if there's an evidence of TB. The other aspect, rather than you can try a GL, but you can also do a stool gene expert. So sometimes stool gene experts
So I want
also
to
help
do a
you.
bacterial diagnosis. So for
Yeah,
which
so
we did
central
GAL.
necrosis can also help you. It can be with Staph aureus also. You can get this with Staph aureus. You can get this with histoplasma. You can
I
get
mean,
this with streptococcus. You can
located
get it with
Staph aureus
Klebsiella.
coming with only mediastinal necrotic lymph node without any focus
It's
anywhere.
rare. It's not possible. So Klebsiella can also cause this.
Yeah.
So we have to. I mean, you're not going to. Nobody's going to do a biopsy of a 1 centimeter node.
No, I mean we have been doing. We have done with the endobronchial ultrasound guided biopsies
it was
in a 3-month baby also. But
Yeah.
this here the thing went like you wanted GL, it was negative. We did
Yeah.
BAL in this child, thinking
BAL
it
may
was,
not help because there's no lung parenchymal.
yeah, absolutely. But that was a more less
Yeah.
invasive, so we did
Yeah.
that. It was again negative.
Yeah.
And so obviously now we are left with two possibilities: mediastinal tuberculosis versus KD. So far we have been talking only about KD, but now this new guy has come into it, and it's very difficult to prove or disprove. So we had this kind of a differentiation. Mediastinal tuberculosis points in favor, fever almost 2 weeks, and necrotic mediastinal lymph node. But odds are partial response to IVIG, thrombocytosis, and leukocytosis, as you said, and then no primary TB contact. As far as KD is concerned, everything is there: fever, thrombocytosis, neutrophilia, leukocytosis, CRP, are everything high, but no KD stigma, no coronaries, and necrotic lymph node. Now it was really a catch-20 situation. So workup for TB, as I said, X-ray was showing mediastinal. X-ray we look for, there was nothing. CT was showing mediastinal lymph node. Gastric lavage, gene expert, AB negative. IGRA we did, which was borderline indeterminate.
So
Yeah.
which IGRA did you do? Did you do a quantiferon
Quantiferon
TB?
gold, it was low mitogen, less than 0.5.
So in such cases, you could actually do a gold plus, which is a 4-tube test.
Okay.
And that is based on CD4 and CD8 both, whereas the 3-tube test, which is normally available, only tests for the CD4. So that gold plus is a much better test.
Just for my knowledge, how much is the sensitivity and specificity of IGRA in our population at
See,
this?
earlier it used to be that IGRA was not very reliable in children less than 2 years. But now with this new IGRAs that are available, which especially the gold plus even younger children, it's pretty much good. It will be very sensitive. Specificity will still be less in less than 2 years.
So good negative predictive value, will say more of. If it is sensitive, then good negative predictive value.
Yeah, good negative predictive value.
Yeah. So here we are stuck now. Mantu was also done for our satisfaction, which again was negative. So no clear evidence of COX. Now what do I do?
Any TB contact, go into the
No,
family history? Okay, stool gene expert, did you do? We can't hear you.
Yeah. No. Your voice is not heard. Dr. Mahesh, you are not heard.
Dr. Mohite, we can't hear you.
Mahesh, not audible.
You are not audible, Dr. Mahesh.
Am I audible now?
Yes.
Am I audible
Yeah,
now?
Yeah, now
Yes.
Okay. So now what do I do? Yeah, I didn't do the stool gene expert. I didn't do the stool gene expert. Maybe I should have done that. I didn't do that.
And also, is the radiologist sure it's central necrosis?
Yeah, that's what he has reported. I got a report.
Yeah, but sometimes they report it like that, and then when it doesn't fit into, you need to take a second opinion about the
No,
radiologist.
we discussed with him specifically because there are some series of cases like this. They are listed there. Can I go? I am audible, right, Dr. Iraj?
Yeah. Now you're audible.
Yeah. So
Any new evolving sign, liver, spleen, new lymph node,
Nothing, nothing. Child
spleen
was in
rash,
fact looking a
nothing.
bit comfortable with whatever we gave,
Oh.
but a fever continued. And now it was very difficult now to tell them endobronchial ultrasound. We told them that we can get some sample and confirm it, but they were by this time, and one of the relative was a pediatrician. So he said he had his own opinions about it. So everything and all. So that is where it's a catch-22 situation.
Did you send for any some immunological marker or some immune deficiency like workup?
There were no clear hints at this point of time. I didn't have any focus. At the end of 2 weeks, I was still nowhere. As far as whether it's infection or what, I didn't know. So on what grounds I could have sent the immunodeficiency markers? And immunodeficiency coming just as a PUO without any focus, going on for 2 weeks is a bit unlikely, you know. Like as we said, going at 2 weeks now, we start thinking of non-localizing bacterials or maybe connective tissue disorders or occasional rare malignancy. So most
So
of the infections are ruled out.
this is not fitting into TB.
Yeah.
You still have to go into autoimmune because you have a lymph node sitting there in the mediastinum. You have thrombocytosis, leukocytosis. So
Fever.
you'll still have to look at autoimmune.
So have you seen which autoimmune you're talking about when there is a lymph node in the mediastinum?
So isolated, you will not get a mediastinal node. There will be other nodes everywhere else. So mesenteric nodes will
He
be
was
there.
not having clinically, he was not having. We did a CT thorax and abdomen. The nodes were only in the thorax.
Okay. Okay.
Shall I move further?
Yes, yes, please do.
I mean, this is exactly what we went through. I mean, you are just trying to analyze in 30 minutes. We were with the child for 7 days facing that class 1 officer and having hundreds of questions. So daily, at least 2 hours of counseling. Very difficult situation.
I think you can do an X-ray of all the family members, including the household maids and everybody.
Yes.
And see, because sometimes you pick up in the maid. And that's where the contact is. If the child has been remaining with the maid for such a long time, then first thing is to do an X-ray of the maid and see.
Perfect. Perfect.
And
But I mean, your problem is even if it is the negative, you cannot rule out TB at 7 months. You can catch up from anywhere.
Dr. Mahesh, so to summarize our case, I think it's still to me it's a fever without focus, with anemia, with thrombocytosis, with some lymph node over there. So maybe some hidden abscess is ruled out. So how about brucellosis?
We did the brucella antibody at this time, and that came negative. Prolonged culture was going on. That so far has reported negative.
Yeah.
And no organomegaly, only thoracic mediastinal lymph nodes. That's a bit unusual. And at 7 months, with a good class patients who don't take any, he's not gone to his native. He's in Mumbai only all his life. So I'll move further, right? So he advised him endobronchial ultrasound guided biopsy.
Yeah.
But family denied further investigations at this point of time. Now, do I start empirical AKT? I mean, RNTCP, NTP also mentions at some point of time when there is no clue but you are strongly suspecting on the grounds, then this is perhaps one reason where one point where empirical AKT may be justified. It may be just 2 or 5% of it. But if you can't get it, I mean, IBUS is something which you do in exclusive places, but 99% places is not available also. So can we start? He is having necrotic lymph nodes in the thorax.
He's not fitting into TB. You have WBC counts which are 30,000.
Yeah.
It's not fitting into TB. Did you repeat a culture?
I did not.
Okay.
And I would go for a second radiological opinion, whether it's a central necrosis there, whether other lymph nodes are available or not. That we can hit. I think that will do it.
Very interesting, and you are perhaps on the right track. So I'll just open up the case. So probable diagnosis at this time was mediastinal tuberculosis for us. But sometimes, you know, few things happen good for you. So patient decided to take DAMA and follow it up. They were regular, I mean, they were having good faith in us. But they said, sir, हम लोग 3-4 दिन रुकते, हम लोग घर पे जाके वापस आते हैं. Okay. So they went home. On follow-up, subsequently we followed up. He came after 3 days. He talked to me. Child was not brought. He said, ठीक है बच्चा. And he came again after 1 week and 2 weeks. Child remained afebrile. So after going on for 2 days, he had fever and then he became afebrile. Had some peeling of skin on fingers and hands, which we followed. We saw after another 1 week. AKT had not started by the parents, which we had recommended. So obviously in retrospect, very likely it was KD.
Yeah.
Now what about that necrosis? That is again, infantile Kawasaki disease with mediastinal lymphadenopathy. Where are we? So question to answer, Why necrotic lymph nodes in Kawasaki? In infantile PO, what will come first, CT thorax abdomen or IVIG? Why I'm asking you this question is very relevant. Had I done the CT prior to giving IVIG and that had given me these necrotic lymph nodes, then I would have been more aggressive in getting a diagnosis even with EBUS. And perhaps I won't have given IVIG to this child with the lymph nodes on. Do you agree with me? Had I seen the necrotic lymph node in the thorax, I don't think I would have given IVIG. Whatever response this child showed later on is probably to IVIG. And then I would have been still lingering. Even with the CT and all those EBUS and all, I won't have got a bacteria or whatever it is. This is very catch-22 situation. Dr. Abhay Bhai.
Yeah.
This child at that point of time when I had a suspect of KD basis and I didn't have a diagnosis. So as a protocol, one would go with a CT
No.
thorax abdomen.
No, I
and
would
that
have,
thorax-
I
what
would
you
have
had done
given
that?
this, I would have done the same thing. I would have given first IVIG. And if the IVIG is not responding, I may think of giving one steroid. But before giving steroid, probably I will go for this CT scan and if possible, even a bone marrow. Or if the peripheral lymph node is, I will go for the lymph node biopsy. That I would have done, not
Dr.
prior to
Ira,
that.
you also would have done the same thing?
Yeah, I would have probably given IVIG. The TB clinically also, and even from your labs, it's just not fitting into.
Yes. Okay. So now in retrospect, we are right because that was a very baffling question to me. Had I done a CT, because that's a protocol in many of the centers. If you don't have a focus, then you will evaluate first, do a CT abdomen thorax, and you get suppose you have done a CT first and got this lymph node. After that, still you would have given IVIG.
See, with a WBC count of 30,000, I would have not really thought of TB.
Okay.
And thrombocytosis, yes, you can get in TB, you can get with anemia, everything, but not with this kind of this thing. And a child who doesn't have contact, 7-month-old, not failing to thrive, not really TB.
Only thing in TB you get this type of the high leukocyte is a miliary tuberculosis where you can have such leukemia reaction. But
You're
here
right.
there is no miliary mottling. So I think I will again reassess that necrotic lymph node and stick to my diagnosis of the KD, incomplete KD.
So you would have given empirical IVIG after
Yeah.
seeing the CT, after seeing the CT also?
Yes, I would have given it because. Yeah.
So I was searching, then I went through ChatGPT and I was this.
ChatGPT.
So when could necrosis be misinterpreted? So I was first, as you rightly did, I was doubting the CT. So CT may show low attenuation areas in inflamed nodes. Radiologists may call them necrotic. But true pathological necrosis on a biopsy is not seen in Kawasaki disease. Bottom line, Kawasaki disease can cause mediastinal thoracic lymphadenopathy, but necrotic lymph nodes strongly argue for an alternative diagnosis and should prompt further evaluation.
Exactly.
And then, of course, I discussed, I was started wondering 10 millimeter itself, whether it is significant. Then some important, interesting information. In less than 2 years, if the lymph node is more than 6 millimeters in width, 2 to 5 years more than 8 millimeters in width, and more than 5 years more than 10 millimeters width, that is supposed to be a significant in mediastinum. And any lymph node having necrosis, calcification or highlighted border, irrespective of size, is significant. So I think that's a good information from this point of time. So that's where that was definitely a bit baffling to me, I'm sure, but you had right from beginning. You were sticking on to your diagnosis of KD or connective tissue. And thank you very much. That was really a wonderful discussion we had. But this is something beyond the protocols, whether CT first or IVIG first. If I do a CT, I see lymph node, a necrotic lymph node, do I still go ahead with the IVIG? I think it requires a lot of wisdom, experience and courage, which I'm sure both of you have, but I'm learning from you. Thank you very much. So I'll go to the second case, which came only 2 weeks after this first one. So this was 3 months old boy, baby boy, the firstborn of non-consanguineous marriage, complaint of fever for 10 days, high grade, up to 103 degrees Fahrenheit, well in interfebrile period. Baby was irritable, no history of coryza and cough, no history of loose motions, no rashes, red lips or no red tongue, no significant family contact of infection. Another FUO, almost I'm giving another FUO to you. So birth history was normal, 2.5 kg at birth, completed immunization till date, development appropriate for the age, treatment prior to admission, admitted and evaluated at a local hospital. He had come to us at 10 days of fever. He received antibiotic ceftriaxone, but fever persisted. He received, I think, 4 days of ceftriaxone, and then he was referred to us as a case of PUO. On examination, he was hemodynamically stable. There were congested lips, few macular spots on the trunk, no lymph node, no organomegaly. What do I do here? 10 days fever. I'm having some subtle few signs here and there, which can be more subjective than objective. Macular rash is there, some congested lips, but otherwise nothing I could. And he has received 4 days of ceftriaxone, and I'm not seeing any focus at this point of time.
What are the investigators? They've done some CBC, urine exam, CRP, and culture available?
Yeah, I'll be giving you to those
Okay.
things.
So
Yeah.
clinically, before with having any investigation, I think this is again a same fever, irritable child, 10 days. There is no focus. So again, the same comes that otitis media or UTI, that is more important, is there. And in between, the child is totally good. So I think it may not be that sick child like or pyogenic meningitis, something like that. So probably UTI is very much on the card. And some rash is there, I think, congested lips, few maculopapillous rash is there. So maybe whether mother is having a history of any herpes or something like that.
No.
So yeah, so this type of some. This is not a second
yes.
case of Kawasaki.
Picture abhi baki hai. But one point, I mean, the previous case and this case, both times you mentioned otitis media. The 7 to 10 days. Have you seen a otitis media carrying the fever for 7 days?
No.
10 days?
In this case, I think it is not there. In the first case,
And
yes.
again, the child is very irritable
Yeah,
in otitis
yeah,
media,
yeah.
and this severe tenderness, something which you cannot
No.
miss clinically. So
Yes. I agree with that. I take it back. Yeah.
Yeah. So now this is what you wanted.
Hmm.
One was prior to admission, another on admission, which we did next day. So he was anemic, counts were on higher side. You are seeing something picture just like the last case.
Yeah.
Okay, CRP high, ESR high,
Sterile
total normal,
there is sterile
CSF
pyuria.
normal, sterile pyuria. This time we didn't get culture positive, but 10 to 12 pus cells. Okay, HGOT-PT borderline high, and CSF, since he was irritable and 10 days, so we did CSF, which was also not showing anything significant, culture sterile. So again, high counts, neutrophilic or other lymphocytic neutrophilic equal, but thrombocytosis, anemic child, and CRP, all inflammatory parameters definitely strongly positive.
Yes.
What do you want to do here now?
What is the BCG scar?
BCG was given. He is just 3 months baby. So far, I'm not seeing a scar.
Okay. Again, the first possibility comes for same Kawasaki disease.
Is Kawasaki. Yeah. Will you give IVIG on this? He's on 10 day. Echo coronary normal. I will come to that. Okay, I'll move further. I'll give you further story.
Yeah.
So echo is normal. We also thought the same, and he came within, and many times you get prejudiced. So you start thinking on the same line again. And he was looking a 3-month child with a FUO, go with any guidelines, that becomes one of the very common differential diagnosis. So echo was done, which was normal. Pro BNP was 961.
So it is high. Yes, it is high.
Yes. IVIG?
I will give IVIG, yes.
Dr. Ira?
Yeah, probably you'd give IVIG.
Okay. You want to do any more evaluations prior to
You
that?
can do various viruses. You can do a Coxsackie virus, enterovirus, and see. But again, that would not cause fever lasting for such a long time.
And leukocytosis.
They will come with some localization by this time on day 10, day 11. Something will come up.
Any skin paining, perianal regions?
Nothing.
There is no edema. There is no edema. So nothing.
No. I dogmatically look at it nowadays because this Kawasaki is really. I still feel we have a lot to learn about Kawasaki. It's coming in a very different colors.
Sometimes they do come in spurts also, it is post some virus.
Absolutely.
And it comes in spurts. Yeah.
Absolutely. So
suddenly you see a cluster of cases.
Yes. So here, almost similar presentation. Now, do I do CT first or I give IVIG first?
No CT.
Huh?
No CT.
No CT. So you want to give IVIG? So perfect.
Yeah.
We are all on the same line.
Yeah.
So we treated with IVIG. Provisional diagnosis infantile KD. IVIG 2 gram per kg given to this child. Aspirin 5 milligram per kilogram. Of course, though the guideline says we did not give steroids because we didn't have a concrete evidence, and steroid I cannot give. Following treatment, hemoglobin 7, TC still high, platelet count are dropping a bit, CRP 25, echo is normal. Now this is almost about 3 days following that, following the IVIG. But child continued to have fever spikes. 3 days after the IVIG. Generally in 24, 48 hours, fever will go down. But this child, now is it incompletely treated? Do I give steroids? What do I do here?
I think the platelet counts has been drastically reduced. If you look at
Yes.
the natural history of the Kawasaki, probably in spite of IVIG, the thrombocytosis persists for quite a long time. So I think something must be cooking inside. And how is the ESR in this child?
I don't honestly remember, but we do ESR on the first occasion always.
Yeah.
So
Because
we didn't repeat it following that. I told you perhaps in my
it is 70 or 75.
35,
Yeah,
74
yeah.
and 35.
Yeah.
So we didn't repeat the ESR again.
And we'll look at the ferritin and something other markers, ferritin.
Okay. So you are looking at bicytopenia and
yes,
macrophage activation.
yes, maybe ferritin.
But after giving IVIG, will you develop macrophage activation? You
I don't
already
know.
given IVIG just now.
I don't have the answer to that.
No, I don't think so. In fact, IVIG is the first line treatment when we see macrophage activation at this age. Dr. Ira, do you agree with me?
Yes, yes. IVIG would have caused the resolution if it was mass.
Absolutely.
The thing is there a family history of anybody having cough cold previously?
The grandmother who is not staying with them, he occasionally goes there. Ask that, dig that history also. So she has cough for some time, but they don't stay with her, and he occasionally goes there. The parents of this 3 months maybe, so not moving out anywhere, and this grandmother is not staying with them.
So
But
do you
yes,
think this is something like
occasionally
a
he has
MISC?
gone to the grandmother. Occasionally he has gone.
Do you think this is something like MISC?
Something like
MISC.
Missy, I mean, we saw that post-COVID. You are talking about that?
Yes, yes.
I mean, are you seeing that now?
Yes.
And that's more of a thromboembolic phenomenon which is causing it?
No. So we are seeing a lot of patients coming with GI related problems. They come with inguinal
Agreed. But
nodes
this
and
child didn't have a neurological, GI, or skin manifestations.
they come to you as Kawasaki's also.
Agreed.
And the way to differentiate between that and Kawasaki would be to look at the CRP. In Kawasaki, your CRP is high, but in MISC or your post-COVID, the CRP would be normal.
Okay.
And there will be more of a
and the treatment would these people would not respond more to IVIG, but they would respond to steroid.
Steroids, agreed.
One way of looking at
Ira,
it is to
in a recent time, in last 6 months, have you seen
keep on
MISC?
seeing occasional long COVID.
What you are having is bias. I have not
Yeah.
seen, honestly. I have not seen. Dr. Abhay, yes, please.
Yeah, there is thrombocytopenia. In MISC, more of a thrombocytopenia than thrombocytosis.
No, you would see thrombocytosis, but what would come is actually lymphopenia over a period of time.
And GI manifestations and
quite common.
thromboembolic manifestations are very predominant in that. We used to do D-dimers very often for that. Here, honestly, I didn't think of it, so I didn't do it.
One way to look clinically for MISC is to look at the heart rate, sleeping and standing. And if you have a POTS, that is a postural orthostatic tachycardia syndrome, where you find a difference of around 20, age-related difference, 20, 30, whatever. And if that is positive, then there's a very high suspicion in any PUO that this could be MISC.
Okay. Okay, that's very interesting information. Honestly, please.
Any new sign, something, eschar or nothing, no? Edema, nothing.
Nothing. I mean, this patient, they really, when you're sleeping, seeing OPD, seeing wherever they are at the back of your mind. So I mean, you're just thinking about am I missing? Am I missing something? But nothing was coming out. No rash, nothing.
So I think if you're planning steroids in this child, then you first do a bone marrow and then see.
Yes. So echo I had already done. His counts were not indicating me directly bone marrow. So we did a CT in this child. Yeah, I did a CT thorax at this child. And I got a large multiple necrotic lymph nodes in the mediastinum. Okay, large and multiple necrotic lymph nodes. Now, there is no parenchymal affection. So we did GL, which was negative. So compression of right mediastinum, we did a scopy in this child. You wanted to see is there any kind of intraparenchymal, sometimes endobronchial tuberculosis, something. But right mediastinal bronchus, due to that mass, the compression was there due to mass. No secretions. Gene expert BAL was negative, bacterial culture was negative.
You'll have to do the mass biopsy.
Yeah,
You
must
have
biopsy.
either CT guided or EBUS guided.
No. So we did the EBUS guided biopsy, transesophageal. This 3 months baby, so you can't put that 5.6 EBUS
Yeah.
through the trachea. So we transesophageally we did it. So right lower paratracheal lymph node biopsy taken, gene expert positive.
Mhm.
So this was a Cox at 3 months with a necrotizing lymph node in the mediastinum. Histopathology is awaited, but this is gene expert positive, rifampicin sensitive. Child is put on 4-drug AKT. So serially 2 cases baffling you in a different direction, making you think first one, whether IVIG first or just CT plus. If CT comes positive, still do you stuck with a necrotic lymph node? Are you still stuck with a connective tissue disorder like KD, or you have to change? So new knowledge, yes, mild necrosis and all that can be fallacious on a CT mediastinal lymph node, and it still could be a KD. And secondly, KD can come with only mediastinal lymph node without any cervical or any other lymph node. I think that's another very good take home from these 2 cases. The first case had lymph nodes only in the mediastinum, no cervical, nowhere in the body. And then that in retrospect, of course, KD is a clinical diagnosis. There is no lab diagnosis to that. But in retrospect, you had a therapeutic response. Child became totally all right. I have followed this child for next 4 weeks and there is no fever and child is doing well. So that's the way it is there. Do we have
Yes,
time? Yeah, please.
Dr. Mohit, exactly what I was telling you. We've seen a lot of patients with TB and COVID, post-COVID, lot of them. And they come to you with findings like MISC and they have associated TB. So
Yeah.
it's not what you're seeing, these necrotic nodes and Kawasaki's, they may actually be MISC with TB.
Yeah.
Could be.
And of late, the counts are very high. In tuberculosis, we see many cases where the WBC are quite high.
So this was what you said. Did you discuss with radiologists? Yes, the CT findings were discussed with radiologists. He said mediastinal lymph node in TB, it's an inflammatory necrosis which is macroscopic, usually visible on gross examination. And KD, it's a ischemic necrosis, usually not visible on gross examination. So KD will be a lymph node usually. So as seen in the chat BDPD also, if you see necrosis, seriously think of alternative diagnosis. Don't get stuck on the KD. That is still a take home. But I think we have to change our protocols. But I don't know exactly what will be the answer in that scenario. IVIG first or a CT thorax first. This patient was lucky enough that he went home DAMA. I'm saying lucky enough that he went home DAMA and the fever went down. Suppose this fever was admitted to your hospital. Fever continued for another 3-4 days. You would have landed on AKT, empirical AKT in most of the scenarios, and had to take 6 months AKT for no reason. So there are a lot of baffling questions and answers in this scenario, but I think everybody has to learn with his wisdom. So we have had our answer and we have had our lesson. I'm sure everybody must have learned the lesson along with us. So do we have time for third case?
I think there's one question from the audience. Somebody is
Yes, you can
asking
take that.
about TB being at this young age. So
You're
it is post BCG vaccine. If it's BCGiosis, you would get at this young age, or if it's a congenital TB, you would get it at this young age. So that's what my question to Dr. Mohite was also, that when you had a mediastinal node TB at 3 month old, you would expect it to be more of a congenital, and with congenital TB, you would expect a lung parenchymal, or you would expect a portal node. Isolated mediastinal lymph node TB at 3 months is absolutely rare. So in such a scenario, you would have to keep in mind some sort of an immunodeficiency in this child.
We are working on that. And congenital lymph nodes before reaching the mediastinum will go through liver. You'll have hepatomegaly.
That's what I said, portal nodes.
There's a
This
portal.
child didn't have hepatomegaly.
Portal
And
nodes.
secondly, I told you probably that grandmother need to be investigated. I've told the parents because this child had stayed for some time with the grandmother. She's been coughing for some time. So whether she's having TB and which she acquired in one of those contacts. And 3 months perhaps is not impossible to get it. I would say
A
6 to 8 weeks.
mediastinal node with that large a mass at 3 months is very
unusual. I totally. But
in fact,
here
you
we
should
got
write up this case because it's a rare presentation.
Yes. So, I mean, we have seen even TB meningitis. I've seen TBM coming at 8 weeks of age. Of course,
No,
that
they
was
can
again a
come. They
congenital.
can come. But mediastinal node as a presentation of TB at 3 months is rare.
Absolutely. Agreed. So, do we have a time for a third case, Dr. Chetan Bhai?
Yes, sir.
Yes.
We have?
Yeah.
We've almost reached 10 o'clock.
Okay. So you want to take any question answers? I'm okay with that. Or if you want me to go for third case, this is a straightforward one, not very difficult one. But again, some learning points. Do I go ahead? I'll go ahead quickly. The 3 months, 7 days old baby, non-consanguineous, one of the premature twins. Other twin is normal and asymptomatic. Is brought with fever off and on for last 3 weeks. Cough since 3 weeks. All right, before this illness, uneventful birth history, referred from pediatric unit for progressive respiratory distress and hypoxia. Was admitted at the previous unit for 1 week. The distress went on. So initial on OPD for 1 to 2 weeks, and then admitted for 1 week, and the distress went on with a fever. So he was sent to us. Weight was 4.6 at 3 months. Birth weight was 2.8 kg. He was one of the twins, as I said. His head circumference was 40, length was 58, appropriate for the age. He was tachypneic. His saturation was 84 at room air. He was already hypoxic. He was hemodynamically stable. Respiratory distress was present. Thus, decreased air entry with bronchial breathing in the right upper zone, infraclavicular. Liver 1 centimeter, spleen not palpable. Rest was all right. What is your thought process?
So, yes.
So there's a pneumonia there. There's a right upper zone. You said there's a bronchial breathing, and he's come to you as respiratory distress.
Already received 2 sets of antibiotics.
Yeah. But he was a premature child, you said. So did he have any
Let
NICU?
preterm, you will say. We was 2.8 kg, let preterm twins.
Okay.
Yes, sir. Yes, sir. Yes, sir.
So here the child has, I think the hypoxia is quite predominant. So probably we are looking at some interstitial lung disease. Usually the children of this age do not cough much. If they cough, I think they may have some airway disease problem may be there. So it may be some bronchiolitis. Of course, the child is premature, it means so it's the high risk for the bronchiolitis complication as well. So maybe something in the form of some bronchiolitis, it can be on pertussis. So any viral infection or any disease which causes interstitial lung disease will be there. The common will be any viral, commonest one being the RSV. Second, it can be even pertussis, or third can be some allergic component, maybe some from the household or something like that. So,
but sir, will the fever continue for 3 weeks in virus? His 3 weeks fever and 3 weeks cough.
No, sir, there may be some complications. Some bronchiolitis with obliterating pneumonia, something like BOP, or bronchiolitis obliterans, something like that. In that case, fever can persist.
Okay. Because I thought fever was not supporting unless you tell me a secondary infection. But that is not very common with RSV. That's common with more of influenza.
Yeah.
And this child
So any post-viral complication can have a long fever. So I think a viral panel and some would have better in this case. The ideal case to go
this
for
case
the.
I saw almost 7 years ago when the viral panels were not very easily available.
Okay.
So there we didn't do this. I've seen about 7, I think 2017.
Yeah.
So this was his serial markers.
Yeah.
So you can see this is the part when he came to us, and this is the part before he came to us. Okay. So you are seeing all anemia all along. Counts are very high, all neutrophilic. Platelets are reasonably on a higher side, and ESR, CRP, all parameters are high. To give kind of a bird's eye view. So nothing, I mean, this is thrombocytosis, leukocytosis, neutrophilic, severe anemia, counts going to 30,000, 31,000.
Something pressing on the airway.
Okay, I'll show you the x-rays.
Yeah.
This was the first serial x-ray. Had come with 4 x-rays to me. This was the first x-ray.
Yeah.
This was the second one. This was the third one. Just 1 minute, please. Yeah, this was the third one, and you can see some breaking lesions here.
Yeah.
And this was the fourth one, which was further progressing.
You don't see any air bronchogram.
And you can see this patent bronchus, right lower. So
in the
here
lower,
you can
but
see.
not in the upper.
Yeah, I mean, initial part you can see the air bronchogram. Then progressively it is certain part being, and this is the part which later on is acquired.
Yeah.
So you can say maybe pneumonic effusion or sort of thing at that point of time. And then you start seeing the breaking up lesions here. And then ultimately it's homogeneous with still you are seeing the breaking up lesions inside.
So
and you are seeing a patent bronchus. I'm sorry.
Go for the CT.
Yes. So he had already done a CT, the previous referring person. Okay. So Referring unit had done a CT thorax for evaluation, reported collapse consolidation right upper lobe, blocking of right upper lobe bronchus with mucus plug. That was a report on the CT, and this was a CT. The right upper lobe is showing almost like collapse. You're hardly seeing any aeration, but there was reported as blocking of the bronchus, which probably is causing. That's what reported. So then he was sent to me for bronchoscopy. Then I've been doing scopy for almost last 15 years. So in our area, they send it to us. So he sent it to cleaning of that mucus. I'm not seeing any lymph nodes or something here, and no other clues.
Yeah.
Dr. Ira, you want to say anything?
No, you will have to do a bronchoscopy. I don't know whether
Yeah.
there's a foreign body or there's a mucus plug or
something.
Obviously, he
Yeah.
had sent it to me, so I had to do it.
Yeah.
He's a senior pediatrician, so I had to do it because, of course, I also wanted an answer. I didn't have an answer at this point of time. So, but what do you expect in a bronchoscope at this point of time?
No, you will just be sending it for cultures, the BAL basically.
Yeah.
So you want the cultures.
Because he has received 2 sets of antibiotics, ceftriaxone, I think vanco, meropenem. People by 3rd week, you are exhausted with everything generally. And by that time, you almost convince yourself that infection is not there or there is some source control which is required, which is not taken care, and he will keep on getting it. Many times it's a source control.
Some lung malformation also getting superadded infected is what you
Yeah,
would
but
also
CT
keep
would
in.
have shown that probably.
Yeah.
Yeah, CT is not reported like that.
I think something is pressing on the bronchus. So I think that is all OPCTs are not pneumonia. So probably we need to think in that.
Right. So with these reports, he was sent to us for scopy. Treatment so far, ceftriaxone, amikacin, meropenem, and clarithromycin. All those
But
things.
no gram positive cover.
No gram positive cover. Yes.
And with that breaking of those lesions, you would actually have thought of
You think of
pneumatosis.
staph. You would have thought of staph. Possible.
Yeah.
Okay, but child would have, without gram positive cover, do you think staph would have still survived or kind of would have gone really
You had
bad?
clarithromycin and amic acid, no?
You are having even meropenem also. But if it is MRSA, then it's not. But
but amic acid, clarithromycin,
Amic acid can
partially.
work for staph.
Yeah, partially it would have worked.
Partial, yeah. Not that.
Okay, so partially treated. We did is GL, CBNAT, because now that is something which is left. I'm sure he hasn't given any direct AKT. So we just had to, on this background, we had to 3 weeks fever, 3-week cough. So we did that and it was negative. Nasopharyngeal PCR will you do at this point of time? 3 months baby with saturation of 84% tachypnea distress, you are a bit reluctant to put in the scope.
Why
why not BAL PCR?
BAL PCR agreed, but that's what I said, to put in a scope. And then my son was not there. He's very aggressive in this. I was not that confident. 3-month baby to put in a 3.5 scope in a respiratory distress with 84% saturation. I mean, fine, I've done few, but I was not that. So
nasopharyngeal
do without that.
PCR is basically for community acquired viral infections.
Yeah.
And it's not for as a pneumonia panel.
It's not a representative sample for pneumonia, I would say.
Yeah, but
where we can do it in absence, we can do it. Yeah, we should do it.
Is it something contraindicated?
No.
It will give some information.
We can take
it will give you information which you will not be able to interpret.
Not a very reliable one.
Yeah, because you will get rhinovirus, you will get RSV,
you can give.
We don't know what to treat.
RSV, pertussis, mycoplasma. These 3 can be.
You don't know whether it's colonizer or it's really there.
So you want me to do the BAL, right?
Yes.
Yes.
So unfortunately, these videos got corrupted. I tried to run it as I did 8 years ago. I have taken it, and in the change, it is corrupted. So procedure finding at carina, protrusion, deformation of the right wall of the trachea at origin of right main bronchus. Thus deformed carina with right main bronch. There was a protrusion from outside. Difficult to negotiate the right main bronchus. Baby started bleeding from the site. It was fragile. It was granuloma with desaturation. So procedure had to be abandoned for some time, and then scope reintroduced after 5 minutes to collect the BAL from the right upper lobe bronchus. So there was definitely some indentation on the right main bronchus with some protrusions and which was fragile, some granuloma. BAL sent for evaluation, routine and culture, and this was it. It was a gene expert positive, sensitive, highly detected TB, gene expert highly detected. So this was 3 months baby with endobronchial tuberculosis. This was 3-month baby with endobronchial tuberculosis with a spread. So gene expert strongly positive, sensitive to rifampicin, no other bacteria grown, endobronchial tuberculosis in 3 months old baby. Take home, TB has no bars in this country, age, sex, rural, urban, rich, poor, you may see anywhere. Thus, in subacute onset, prolonged disease, always first differential has to be DD, whatever it may be. I think you have to learn a lot about TB as well as KD. So that's the reason I chose these 3 cases to be presented today. Attempt definitive diagnosis always, no role of empirical AKT in today's era. Because it's now every investigation is available. I don't think one should start AKT empirically. A consultant in India must know everything about TB. So that's where I end. Thank you very much. And your final comments, Dr. Abhay Bhai and Dr. Ira Madam.
I think you have also said TB can present in any form, number one. And nowadays we have seen a lot of Kawasaki. And I think to salvage the coronary, I think high index of suspicion is very, very important. So when there is a fever is more than 5 days and all the complete criteria may not be there. So we see a lot of incomplete Kawasaki and they require IVIG. That is more important. And of course, TB can present and any fever which is more than 7 days, all other indications ruled out. I think CT contrast is very important. Usually we go for the HRCT or CT. So one simple message, always go for the CT contrast and always use more and more IBUS. It's a very good tool for the diagnosis.
Right. Okay,
So,
Ira,
Dr. Mohita, very excellent cases and a lot of learning points. And I think when you get your 4th case, you will still be in that dilemma, CT first or IVIG first.
Absolutely.
Yeah. So TB comes in all possible ways. You can get TB coming to you as in fact, I had a child with TB who came with a white eye, went to Tata, they thought it is retinoblastoma, enucleated the eye, and that turned out to be TB. So it can come in any form. And as you said, that any fever that lasts for a longer time, think of TB, no matter what the age group. Yeah. So thank you very much.
Over to Dr. Manish.
Yeah, thank you very much, sir. Actually, the cases initially started very simply and then they went like anything. So, and the first case, as you told, the VIP patient, it becomes very difficult to do a single investigation, a single prick without reason in a VIP patient. So, it's a really tough task. We have our most sincere attendant, Dr. Rangnath Darur, sir. Sir, a few comments from you.
The similar case, similar history, but the baby is from NRI. He is from Israel. So I am still in dilemma whether to start or not because the node is seen in the pre-auricular over the parotid area. So still I'm keeping it for follow-up and see. 1 month is over. The next we have to review. Otherwise, all the 3 cases that you have presented have been facing the same problem here. Thank you.
Yeah, thank you, sir. Palani, sir.
It was a really good learning. Thanks, Magesh. And as usual, Madam is there and Dr. Abhay is there. And now, as usual, from PGH Chandigarh, plenty of papers are coming. Any fever without focus in a young infant or in infancy, when it is crossing 5 days, always have back of the mind after ruling out all the infections. Now, KD is becoming very common now, particularly in the infants, when fever without focus. With incomplete KD is becoming very common, so we have to be very careful not to miss it. Thank you. Thank you. It's a really wonderful learning. And I don't know how far this less than 3 months baby is coming with such type of endobronchial TB and mediastinal TB. It's the first time I'm hearing. But because I had seen disseminated TB in 3 months, miliary TB in 3 months, not mediastinal or endobronchial TB. This is a good learning for him. Thank you. Thank you.
I think it is because of the available good CT contrast that we are picking more and more. Yeah.
Yes. Dr. Chetan Trivedi.
Yeah, thank you so much. Sorry, I couldn't be online. I would definitely look at it on YouTube. Thank you, Dr. Irasha ma'am, for being there. And of course, Dr. Mahesh Mohite sir volunteered himself to have that interesting cases. And Abhay Shah is always at, handy for us because we can say at any last moment. Even yesterday, I called him because we decided just the day before yesterday, Mahesh Mohite said I'll be doing the case. Thank you so much. You really made the things worth attending. So thank you so much.
Thank you very much. Thank you.
Thank you, everybody.
Thank you. Good night.
Thank you.
Thank you. Good night, everybody. Bye.
Good night.
Good
Bye,
night.
Palani.
Thank you.
Daruru sir, bye
Thank you,
bye.
everyone.
Bye. Bye.
Alani.
Mahesh, thank you.
Thank you,
Hi,
Sunny.
Chetan.
Thank you very much.
Mahesh sir, thank you so much. Sorry, I couldn't be there.
No, you can even a
Thank you,
YouTube recording is
Darur
there, you
sir.
can
Thank
see.
you, sir.
My flight
Thank you,
timing was
Dr.
same.
Darur.
Bye.
Initially, it was not planned. Basically, then I preponed, so that's why it was in flight.
No issues. Thank you
Yeah.
very much. Thank
Thank
you.
you so much.
Manish,
Thank you,
thank you.
Manish.
Manish, good
Thank
night.
you.